So today we'll start deal with the anti-Parkinsonism drug. Okay, the drug used for the treatment of Parkinsonism is called as anti-Parkinsonism drug. Now, a couple of points you need to remember for the exam. Parkinsonism. Parkinsonism. So basically, it is a neurodegenerative disorder. It is a neurodegenerative disorder affecting the extrapyramidal system. So where this system is actually, it is in the basal ganglia. Okay, specifically in basal ganglia, which region? Substantia nigra. Okay, so it's a neurodegenerative disorder affecting the substantia nigra, which is present in the basal ganglia. So that is a point you need to remember. And what happens there? There will be a decrease of dopamine, decrease of the neurotransmitter called as dopamine. So dopamine, you know that it is a neurotransmitter. Okay, dopamine is a neurotransmitter, and this neurotransmitter can act as inhibitory as well as excitatory. Okay, so dopamine can is an example of both inhibitory and excitatory neurotransmitter. Okay, whereas the aspartic acid or glutamic acid, they are example for excitatory neurotransmitter. Whereas if you take glycine or GABA, they are example for inhibitory neurotransmitter. Okay, whereas the dopamine is an example for both inhibitory and excitatory neurotransmitter. Okay, but what happens here? So here in Parkinsonism, there is a deficiency of this dopaminergic activity. That means there will be decrease in the dopamine level. Okay, so that is the main thing you need to remember. In Parkinsonism, the neurotransmitter dopamine will be less in the basal ganglia substantia nigra. That means the dopaminergic activity will be less. Okay, so now what are the symptoms in Parkinsonism? You know that the movement of the patient will become less. The movement or the speed of the movement will come down. So that is called as bradykinesia. Kinesia means movement. Brady means decrease in the movement. Brady means decrease. So decrease in the movement, that is called as the bradykinesia. The joints will be having rigidity, rigid joints. Tremor will be happening. Defective posture. Saliva secretion also would be very high. Cialuria. So these are the general or the commonly seen symptoms in a Parkinsonism patient. So it's a neurodegenerative disorder where you can see the deficiency of dopamine, where in the basal ganglia substantia nigra. Now, how this disease happen? It's unknown most of the cases. Exact reason is not known. And one of the reason is Wilson disease. Wilson disease, you know, it's a copper poisoning. Okay, so it's a rare, although it's a rare cause, it's considered to be one of the cause of Parkinsonism. Now, certain drugs will cause this Parkinsonism. Drugs can cause Parkinsonism. Okay, one main example you need to remember is phenothiazines. Phenothiazines can cause Parkinsonism. What is phenothiazine? The main example is chlorpromazine. They are antipsychotic drug, right? Antipsychotic drugs. So now, when you give antipsychotic drug, why Parkinsonism happen? You know that in psychosis, what is the dopamine level? The dopamine level will be very high in the brain. Whereas in Parkinsonism, what is the case? In Parkinsonism, as I already told, dopamine will be less. So that is the difference. In psychosis, it is opposite of the Parkinsonism, where the dopamine will be excessive or compared to the normal level. Dopamine level will be very much elevated in the psychosis, whereas in Parkinsonism, it is less. So when you wanted to treat psychosis, what you should do? Because in psychosis, dopamine level is very high. You need to give or you need to decrease the dopamine level. Correct. So in the treatment of psychosis, you will give a dopaminergic antagonist, or you will try to decrease the dopamine level. Okay. So when you give a drug for for psychosis, that will decrease the dopamine level, and if it goes below the normal level, that can result in Parkinsonism. So that is why I told some of the antipsychotic drugs like phenothiazines, butyrophenones like haloperidol, phenothiazines like chlorpromazine can cause Parkinsonism because they decrease the dopamine level. Okay. Now, you know that the anti-emetic drug metoclopramide. Metoclopramide will block the is a D2 blocker. Is a D2 blocker. It can decrease the dopamine level. Correct. So that is why metoclopramide, although it's an anti-emetic drug, it can cause Parkinsonism on excessive use. Now, this antihypertensive reserpine has also shown to create Parkinson. So sometimes the question will be like this: which of the following drug can result in Parkinsonism, or which of the following drug is known to cause Parkinsonism? So what should come to your mind is that the antipsychotic drug, which are the main example: phenothiazines, haloperidol. Haloperidol means which comes under which class? Butyrophenones. And chlorpromazine is a classical example for phenothiazine. What about the anti-emetic drug? Yes, D2 antagonist like metoclopramide and the antihypertensive drug like reserpine can cause Parkinsonism. Okay, so this question can come for the exam. Which of the following drug can cause Parkinsonism? Okay, All right. Now we'll move to the classification of anti-Parkinson drugs. Okay. So as I already told, in Parkinsonism, the dopamine level will come down. So normally in our body, this dopamine in our CNS, the dopamine and acetylcholine will be in a balance. Acetylcholine and dopamine will be in a balance. Now in Parkinsonism, I told you dopamine level will come down. So what you need to do during the treatment, you need to increase the dopamine level. So you can give a drug which affect the brain dopaminergic system. So that is one strategy, because the dopamine level is very less. You need to give a drug which can increase the dopamine level. So that is the first strategy. We can give a drug which can increase that brain dopamine level, and that is the first class. Now second strategy, I told you, acetylcholine and dopamine is in a balance. Now, in Parkinsonism, dopamine will come down, so the balance will be lost. So what could be the other strategy? You can bring down the acetylcholine to make the balance, correct? So if you bring down the acetylcholine, dopamine and acetylcholine could be in the balance. So basically, you need to create a balance between dopamine and acetylcholine. In Parkinsonism, dopamine will come down. So what you can do, you can bring down the acetylcholine level so that they will be in the balance. So they are called as they are drugs affecting cholinergic system. That is means you can give an anti-cholinergic drug. Hope it is clear. So these are the two strategies what you need to do. One is you can increase the dopamine level, or you can decrease the acetylcholine level. So that is the second class, that is the drugs affecting the cholinergic system. Now coming to the drugs affecting cholinergic system, as I told you, you need to decrease the cholinergic and acetylcholine. That means anti-cholinergic drug you need to give. Okay, opposite of acetylcholine means you need to decrease the acetylcholine, so you need to give an anti-cholinergic. Now there are drugs which can decrease the acetylcholine in the central nervous system. They are called as central anticholinergic. Okay, so they are called as central anticholinergic. Now some of the histamines also have this anticholinergic property, so they can also be used in the absence of central anticholinergic. So the drugs affecting, or the drugs which is given to decrease the acetylcholine, can be divided into two categories: central anticholinergic and antihistamines with anticholinergic activity. Now you need to remember all these examples. The examples for central anticholinergic is benzhexol. The second example is benztropine. The third example of central anticholinergic is biperidone. And the fourth example is procyclidine. Okay, so benzhexol, benztropine, biperidone, procyclidine are examples for central anticholinergic. They will decrease the acetylcholine level. These drugs can decrease the acetylcholine level. That is how it can create a balance, or recreate a balance. Now also you can remember benzhexol is also known as trihexyphenidyl. Benzhexol is also called as trihexyphenidyl. Okay. Now, apart from the central anticholinergic, I told you there are antihistamines. The drugs which is given to decrease histamine level, they also possess anticholinergic activity, especially the first generation antihistamine like promethazine, diphenhydramine, dimenhydrinate, or phenadrine citrate. Okay, so these are actually antihistamines. However, they have the ability to decrease the acetylcholine level. So they are antihistamines with anticholinergic activity. Promethazine is the very commonly used drug where it can decrease the acetylcholine level. Hope it is clear. So basically, we divide into two categories: the drugs which can increase the dopamine level. Second category is the drug which can decrease the acetylcholine level. Okay, so we have told about central anticholinergic and the antihistamine, and the examples you need to remember. Now let's move on to the drugs which can increase the dopamine level. Okay, so far we have discussed about drugs which can decrease the acetylcholine level. Now we will talk about drugs which can increase the dopamine level. So in Parkinsonism, dopamine will be less in the basal ganglia. So what could be done actually? You can directly, can't you give directly a dopamine? Can you give dopamine for the treatment of Parkinsonism? No. The reason is that it cannot cross the blood-brain barrier. Ultimately, it has to reach the brain. In the CNS, in the basal ganglia, the dopamine is level. But the problem is that this dopamine cannot cross the blood-brain barrier. It is hydrophilic. It cannot cross the blood-brain barrier, so that it cannot reach the brain. So even if you give dopamine, there is no use. That is the first point you need to remember. Moreover, dopamine will be readily metabolized in the periphery. Okay, if you give dopamine, it will be immediately metabolized in the serum. Okay, so that is also one reason. So dopamine, giving dopamine as such is not a treatment. You cannot give a treatment. So what you could do, you can give a precursor of dopamine, which is called as levodopa, which can cross the blood-brain barrier and reach the brain. Now, when you reach the brain, this levodopa can be metabolized to dopamine. So that will serve the purpose. So that is why you can, rather than giving dopamine, you can give a dopamine precursor. And the answer is dopamine precursor. The example is levodopa, abbreviated as L-dopa. Okay, so that is the first thing you need to know. Now, when you give levodopa, the problem is that in periphery also they will be metabolized by an enzyme called as a dopa decarboxylase. When you give 100 molecules of levodopa, when you give 100 molecules of levodopa, 90 will be metabolized in the periphery itself. Only 10 may reach the brain actually. In brain also, in the inside the brain also, there is a dopa decarboxylase, which is very much needed to convert it to dopamine. So there it is a benefit. Dopa decarboxylase in the brain is a useful thing because it can convert the levodopa into dopamine. Whereas in periphery, this levodopa will be converted to dopamine. But what is the use? It can there is no use because it cannot cross the BBB. It cannot. This dopamine cannot cross the blood-brain barrier. Rather than it can go and stimulate the dopamine receptor in the periphery, so it can create side effects. So that is one of the drawback of levodopa. When you give levodopa alone, the problem is that it will be readily metabolized by an enzyme called as the dopa decarboxylase, especially the peripheral dopa decarboxylase. So in central also there is dopa decarboxylase, but that is central dopa decarboxylase. Okay. So what we can do is that when you give levodopa, you can give a drug which can inhibit this enzyme. That is peripheral dopa decarboxylase. So that is called as peripheral dopa decarboxylase inhibitor. Peripheral dopa decarboxylase inhibitor. So peripheral dopa decarboxylase inhibitor you can give. And the example for peripheral dopa decarboxylase inhibitor is carbidopa and benseroside. So whenever you give levodopa, if it is in a combination with carbidopa, more amount of levodopa can reach the brain. If you give 100, that entire amount can get into the brain. Where if you give simply only levodopa, it will be metabolized. Most of the levodopa will be metabolized in the periphery. So levodopa should be given along with a dopa decarboxylase inhibitor, that is peripheral dopa decarboxylase inhibitor. And the example you need to remember is carbidopa and benseroside. Okay, so that is one thing. So basically, we were by these first two strategies, we were trying to increase the dopamine level. Agree? Either by giving levodopa or by to increase the efficacy of levodopa, carbidopa could be given, or benseroside could be given. Now, second thing is that this see, this is, suppose this is a neuron. The dopamine is stored in the vesicles. Now this is the brain. So there are receptors like a D2 receptors. This dopamine will come here. It can stimulate this dopamine receptor. That is how it will execute the action. Now what you could give, you can give a drug which can act like dopamine, which can go and stimulate this dopamine receptors, D2 receptors. So that is called as dopaminergic agonist or D2 antagonist. So the point is that you wanted to increase the dopaminergic activity. So you can give a drug which can go and stimulate the D2 receptors in the basal ganglia. So they are called as D2 antagonist or dopaminergic agonist. We can divide it into two categories. So the initial drugs which was acting as a D2 antagonist was obtained from ergot plant. You know that Claviceps purpurea ergot. Okay, so ergot, they were derived from the ergot plant, and they were having D2 binding property. They were having affinity towards the D2 receptor, so they were D2 agonist. So since they are derived from ergot, we will call it as ergot derived D2 agonist. Okay, and the example you need to remember is bromocriptine, pergolide, cabergoline, lisuride. So bromocriptine, pergolide, cabergoline, and lisuride are examples for ergot derived D2 agonist. You look at the name pergolide, ergo. The name ergo is there. You look at the name cabergo, ergo. Okay. Other than that, bromocriptine as well as lisuride also you better remember. Okay. Some of the D2 agonist is not derived from the ergot, so they are called as non-ergot derived. And these are the drugs. Actually, this ergot alkaloids have a lot of toxicity, so they are not preferred nowadays. And most preferred drug will be the non-ergot D2 agonist. And the example is ropinrole, pramipexole, rotigotin, apomorphine, pyribedyl. Okay, so these are the non-ergot alkaloid having the D2 agonist property. Okay, out of which the most commonly used one is ropinrole and pramipexole. Okay, ropinrole and pramipexole, also rotigotin, also are commonly used. Okay, so that is what it is. Okay, so you can stimulate the D2 receptors. Okay, now the problem is that when this dopamine reaches the synapse, it will be metabolized by some enzymes called as MAO enzyme, especially monoamine oxidase B, MAO B enzyme. It is also metabolized by another enzyme called as catechol-O-methyl transferase, abbreviated as COMT. Okay, so that is also a problem. When the dopamine is released into the synapse, before it goes and bind to the receptor, it will be metabolized by two enzymes. So one enzyme is called as MAO-B, and the second enzyme is called as COMT. So what we can do, if we can inhibit this MAO-B enzyme, or if we can inhibit this COMT enzyme, we can increase the level of dopamine in the synapse. Correct? So we can give some drugs which can inhibit that enzyme. Okay, so as I told, dopamine will be metabolized to the metabolites, corresponding metabolites, by an enzyme called as monoamine oxidase B. Okay. Now, if you can inhibit this enzyme, you can increase the dopamine level, correct? So they are called as MAO-B inhibitors. And the example is seligilin, rasagilin. You look at the name, gilin, seligilin, rasagilin. And safinamide is a new drug which is used, which is a MAO-B inhibitor that can be used in the treatment of Parkinsonism. Okay, so MAO-B inhibitor could be given, which can inhibit the MAO-B enzyme, and the dopamine level could be increased. Similarly, I told you dopamine is also metabolized by another enzyme called as catechol orthomethyl transferase. Catechol orthomethyl transferase. So it will be metabolized to its corresponding metabolite. Now, if we can inhibit this enzyme, we can increase the dopamine level. So that is another strategy to increase the dopamine level. You inhibit the COMT enzyme. COMT is nothing but catechol orthomethyl transferase. So if you can inhibit this enzyme, the dopamine level could be increased. And the example is entacapone, tolcapone, opicapone. Okay, so these are the examples for COMT inhibitor. So we have told about the dopamine precursor like a levodopa. Then we told about carbidopa, which is a dopa decarboxylase inhibitor. Then we told about drugs which can go and bind to the dopamine receptor, D2 agonist, ergot, non-ergot. Then we told about the two enzyme inhibitors, MAO-B inhibitor, COMT inhibitor. Okay, now we can also give a drug which can stimulate this dopamine stored in the vesicles and release the dopamine immediately. So that will also increase the dopamine in the synapse. We can give a drug which will increase the release of dopamine from the vesicles, and that drug is called as dopamine facilitator. Or they are drugs which can increase the release of dopamine, and the main drug is the amantadine. Amantadine. It was used normally earlier. It was used as for the influenza A virus. Influenza A virus, and it has also an anti-Parkinsonism effect. How it has anti-Parkinsonism effect? It has the ability to increase the release of dopamine. Okay, or it is a dopamine facilitator. Okay, so these are the examples for the class. These are the examples and the strategies used for the class used for the treatment of Parkinsonism. So we have done with the classification of anti-Parkinsonism drug. I hope it is clear. Now, before coming to the details of each drug, couple of points you need to remember with the dopamine receptor. So I told you dopamine, after reaching the synapse, it will go and bind to the dopamine receptor, correct? It will go and bind to the dopamine receptors. Now, dopamine receptors are of D1, D2, D3, D4, D5. I told you dopamine can act as excitatory as well as inhibitory. So out of the D1, D2, D3, D4, D5, D1 and D5 receptors are excitatory, whereas the D2 receptor, which is seen in the basal ganglia, is mainly inhibitory. D2, D3, D4 are inhibitory, whereas D1, D5 are excitatory. Now, dopamine receptor is an example for G protein coupled receptor. One of the most abundant receptor in our body is G protein coupled receptor. Dopamine receptors comes under that class. They are examples for G protein coupled receptors. Dopamine receptors are example for both excitatory and inhibitory. And mainly in this chapter, we are mostly concentrating on the D2 receptors because it is present in the basal ganglia, substantia nigra. And we have told that in Parkinsonism, the dopamine level in the basal ganglia, substantia nigra, was very less, correct? So we need to stimulate the receptors of dopamine in the substantia nigra, which is D2 receptor. That is why we gave a drug called as D2 agonist. Hope it is clear. So 2 points you need to remember. It is a G protein coupled receptor, and dopamine receptor are both excitatory and inhibitory. I hope it is clear. Now we'll move to the first drug from this chapter, that is levodopa, abbreviated as L-dopa. So the first point you need to remember, it is a prodrug. As such, levodopa does not have any effect. Now this is the structure of levodopa. Okay, this is the structure of levodopa. You look at the structure. Now in the structure, there is a benzene ring is there, OH group is 2 OH group is there, and a CH2 followed by this CH2. Now here, basically, what is the full form of levodopa? L-dopa. It is abbreviated as L-dopa. What is dopa means? What do you mean by dopa? Dopa is nothing but dihydroxy phenylalanine. Dihydroxy phenylalanine. So D from that hydroxy OPA. That is why it is called as dopa. Now you look at the structure. 2 hydroxy group is there. Phenyl group is there, dihydroxyphenyl, and this CH2CH, all this is called as alanine. So basically, it is a dopamine is a amino acid derivative. Okay, which amino acid? Dihydroxyphenylalanine. Okay, now from this levodopa, this carboxyl group will be coming out as carbon dioxide. Okay, that means the carbon dioxide will be removed. That is called as a decarboxylation reaction. So the carboxyl group, this carboxyl CO2 group will be removed. So what will be left? This hydrogen will come here, CH2, NH2, correct? So this structure is called as dopamine. So what happens is that when you give dopa, as I already told, there is an enzyme called as dopa decarboxylase. Periphery also it is present, central also it is present. In periphery, it will be a problem and we need to inhibit that enzyme. But when it reaches the brain, there is central dopa decarboxylase which will metabolize it into dopamine. This dopamine will go and bind to D2 receptors. That way, it will stimulate the D2 receptors and Parkinson's symptoms could be reduced, or the patient will be a condition can be improved. Okay, so hope it is clear. So which is the enzyme that converts the prodrug levodopa into dopamine? What will be your answer? Dopa decarboxylase. Clear? Fine. Now we will move to some of the actions of levodopa. So as I told you, after dopamine comes, dopamine goes and binds to this dopamine receptor, D2 receptors, correct? It can also go and bind to the beta 1 receptors, beta 1. Do you know where beta 1 is present? Beta 1 is present in the heart. So if it goes and binds to the beta 1 receptor, what heart can be stimulated? So what about the heart rate? Heart rate will increase. If heart rate increases, what you will call? Tachycardia. So in the cardiovascular system, it can create tachycardia. Okay. Now D2 receptor, when it is stimulated, it result in vasodilation. Blood vessels will be dilated. If blood vessels is dilated, what can happen to the BP? BP will come down. So that is result in hypotension. It can result in hypotension. So just need to remember, it normally stimulates the D2 receptors, but at higher doses, it can also stimulate the beta 1 receptor, which can go and stimulate the heart. That is why this tachycardia problem will come. Hope it is clear. Okay, so that is the two actions you need to remember: tachycardia as well as postural hypotension. Okay, all right. Now it will go and stimulate the chemoreceptor trigger zone, CTZ. You know that what is chemoreceptor trigger zone, right? So it can go and stimulate the chemoreceptor trigger zone. You know that if that receptor CTZ is stimulated, what can happen? Vomiting can come, nausea can come. So that is also a problem for levodopa. Since it stimulates the CTZ, levodopa can result in vomiting and nausea. It also have an endocrine effect where it will decrease the prolactin secretion. So three things you need to remember. What is the effect of levodopa in CVS? What happens to the heart rate? Increased heart rate. What about the BP? Postural hypotension. What about CT? What is the action on CT? Is it will stimulate it. So what can happen? Vomiting can happen. And in endocrine, it will inhibit the secretion. I hope it is clear. Now we'll move to the pharmacokinetics. First point, you need to pharmacokinetics of levodopa. It has a high first pass metabolism. The moment you give levodopa, before reaching the circulation, it can get into the liver and it can be metabolized in the liver. So that is called as first pass metabolism or pre-systemic metabolism. So that thing is very high with respect to the levodopa. Now the point I already told, when you give levodopa, most of the levodopa will be metabolized in the peripheral tissue. I told you dopa decarboxylase enzyme is present in the periphery. That will metabolize, and that this enzyme will convert levodopa. This enzyme will convert levodopa into dopamine, especially the peripheral dopa decarboxylase. Now this dopamine can go and bind to the dopamine receptors in the periphery. So that can result in adverse effects. So that is one problem. And when you give 100, 99 went to the metabolized in the tissue, only 1% crossed to the BBB. So that 1% only will create a clinical improvement. So which is actually not a good bioavailability. You give levodopa, only 1% will reach the brain. That will try to give a clinical effect. But do you want that? Do you want such a drug? Yeah. So whenever you give levodopa, you need to inhibit this step. Which step? You need to inhibit this peripheral dopa decarboxylase. So that is the point. Already I have told you. This drug is dopa decarbo. You should give a drug which can inhibit this enzyme that is peripheral dopa decarboxylase. That is carbidopa. And why? The reason is that because levodopa is metabolized by an enzyme called as dopa decarboxylase. Okay. Now one more point you need to remember from the pharmacokinetics: the vitamin B6. You know that mostly when patient comes to the hospital for any treatment, the clinician may give vitamins. But if you give vitamin B6 for a Parkinsonism patient, it is not a good way to do, or it should be avoided. The vitamin you should avoid in Parkinsonism patient is the pyridoxine vitamin or vitamin B6 vitamin. Vitamin B6 or pyridoxine should be avoided in the Parkinsonism patient. Why? Because this vitamin B6 is a stimulator of this dopa decarboxylase enzyme. It is a cofactor of the dopa decarboxylase enzyme. I told you, whenever you give levodopa, the peripheral dopa decarboxylase will metabolize that, which is not a good thing. So if vitamin B6 is there, it will, rather than inhibiting, it will stimulate this enzyme. So that if you give levodopa will be immediately metabolized. So the efficacy can come down. So whenever you give levodopa, you should not give the vitamin B6. So in the exam, the question will be that which vitamin B complex should be avoided in the levodopa taking Parkinsonism patient? The answer is vitamin B6. What is the other name of vitamin B6? Pyridoxine. Okay, because it is a cofactor of the peripheral dopa decarboxylase. So the efficacy of the levodopa will be lost. Hope it is clear. Okay, so the point you need to remember from the pharmacokinetics is it high first pass metabolism. 99% will be metabolized in the periphery by an enzyme called as peripheral dopa decarboxylase. So that is why you need to administer a carbidopa along with the levodopa. And the third point you need to remember, vitamin B6 should not be given while administering levodopa. Hope it is clear. Now moving to the adverse effect, as I told you, this dopamine or this levodopa can stimulate the chemoreceptor trigger zone. So what happens? Nausea, vomiting can happen. It can stimulate the dopamine receptor, which can cause vasodilation. So if vasodilation happen, what will be the problem? Yes, postural hypotension. It can stimulate the beta-1 receptor. So I already told tachycardia, heart rate can increase. So that can create arrhythmia, cardiac arrhythmia. Now, apart from that, the movement will be difficult. So dyskinesia, that is also an area of levodopa. Dyskinesia, painful movement, dyskinesia. Okay, or involuntary movements can happen. Okay, also I told you we are trying to give levodopa, which will increase the dopamine level, correct? So if dopamine level goes beyond a limit, it can result in psychosis. I told you in psychosis, what is the dopamine level? Increased dopamine will be there. So the mood change or the behavior abnormality can be observed when you are giving levodopa for a long term. So psychosis can also happen because if it increases the dopamine level beyond the limit, it can get into psychosis. Okay, so these are the ADR you need to remember: nausea, vomiting, hypotension, tachycardia, dyskinesia, psychosis. Hope it is clear. Now coming to the drug interaction of levodopa, already I told you which vitamin should not be given. Yes, vitamin B6 or pyridoxine should not be given because it is a cofactor of the peripheral dopa decarboxylase enzyme. So the efficacy of levodopa will be decreased. Clear? Now, antipsychotic drugs should not be given in levodopa. I already told you antipsychotic drugs will decrease the dopamine level. Correct? So that will just reverse or antagonize the effect of the levodopa. So antipsychotic drug, especially chlorpromazine like drugs belonging to the phenothiazine category, haloperidol drug like butyrophenols. Okay, so phenothiazine, the main example is chlorpromazine. Butyrophenol, the main example is haloperidol. So these antis are typical. They are called as typical antipsychotics. Typical antipsychotic should not be given in levodopa containing. Their drug interaction can come. The effect of levodopa will be reduced or reverse. Hope it is clear. Now the antiemetic drug metoclopramide can we give metoclopramide? I told you in the ADR, nausea, vomiting tendency will be there when you are taking levodopa. So to treat the vomiting, can you give metoclopramide? No, you cannot give metoclopramide because metoclopramide is a D2 antagonist. So already the dopamine level is less in Parkinsonism patient. If you block that, then what is the use? So you should not give metoclopramide or the antiemetic drug metoclopramide should not be given to treat the vomiting in the levodopa taking patients. Hope it is clear. Rather than what you should give, you can give domperidone. Rather than giving metoclopramide, you should give domperidone containing drug, domstal. Okay. So the point you need to remember, you should not give metoclopramide. Drug interaction can happen. It can also reverse the effect. Now, I told you dopamine can be metabolized by MAVO, right? So MAVO, monoamine oxidase, are of two types, monoamine oxidase A and monoamine oxidase B. Now, there are certain drugs which can go and inhibit both of the enzymes. Okay, so they are called as non-selective MAVO inhibitor, and the example is phenylephrine. Okay, so if you inhibit both the enzyme, the problem is that this noradrenaline, adrenaline, serotonin, they are all metabolized by monoamine oxidase A. Okay, whereas dopamine is metabolized by monoamine oxidase B. When you are giving a non-selective MAVO inhibitor like phenylephrine, it will go and inhibit all these enzymes, correct? It will go and inhibit MAVO A. It will go and inhibit MAVO B. What can happen? Noradrenaline level can increase, adrenaline level can increase. So that can result in hypertensive crisis. Okay, because noradrenaline, the sympathetic system will be stimulated. Okay, so you should not administer a non-selective MAO inhibitor along with a levodopa kind of drug because it can result in hypertensive crisis. So in drug interaction, you need to remember vitamin B6 should not be given. Typical antipsychotic should not be given. The antiemetic metoclopramide should not be given, and the non-selective MAO inhibitor called as phenylephrine also should not be given. Hope it is clear. Now, where it is contraindicated? Yes, acute psychosis patient, because in acute psychosis patient, the dopamine this level will be very the acute psychosis patient, you will be giving antipsychotic drug. So in that case, the dopamine will be the treatment will be to reduce the dopamine. So if you give in that case levodopa, so the dopamine will not increase. So that is why it is contraindicated in acute psychosis patient. Also, one more reason I told you. So when you give this levodopa, dopamine level will increase. Correct? Dopamine level will increase. So in a psychosis patient, already dopamine level will be high. So that will further increase. So that is also one reason why you should not give to the psychosis patient. Okay, because in the ADR itself, we told levodopa can cause psychosis. Okay, so you should not give in a psychotic patient. All right. So that is all about levodopa. So we have told about the mechanism. We have told about the pharmacokinetics. We have told about the ADR. We have told about the drug interaction. We have told about the contraindications. Now I told you, whenever you give levodopa, the problem is that it will be metabolized by peripheral dopa decarboxylase, correct? Peripheral dopa decarboxylase. So that is a main problem. So you can inhibit this enzyme by that peripheral dopa decarboxylase like carbidopa bensericide. Okay, so they are peripheral dopa decarboxylase inhibitor. Now one more advantage is there, it will not cross the blood-brain barrier. So what is the good thing? Levodopa in the brain will not be metabolized. The dopa decarboxylase in the brain will not be inhibited. So in brain, levodopa can be converted into the dopamine, which is needed also. Okay, but in periphery, it will inhibit the peripheral dopa decarboxylase. It will not cross the blood-brain barrier, which is a good property. Okay, therefore, the dopamine in the brain can be increased. Okay, so hope it is clear. Now, when you give this levodopa along with the carbidopa or bensericide, the advantage is that I told you it will inhibit the peripheral decarboxylase. So if peripheral, it will inhibit that enzyme. So in periphery, dopamine will not be formed. And we don't want also that. If in periphery, if dopamine is formed, it can go and bind to various receptors. So that means it can decrease the peripheral adverse effect of levodopa. And one more other advantage is that it can increase the half-life of the levodopa. Nausea vomiting will be less because in periphery, it will not be converted to dopamine. Cardiac problem can become less. Also, if you give it with the levodopa, even vitamin 6 reversal of levodopa do not occur. I told you vitamin B6 should not be given because vitamin B6 is a cofactor. Now, if you give carbidopa kind of drug, that will not be a much problem. However, it's better to avoid vitamin B6. So remember that. So these are the advantages. The response will be very fast. The half-life will be increased, the peripheral ADR will be decreased, cardiac problem will be less, nausea vomiting will be less. Now, even if you give carbidopa, one problem will not be resolved. The answer is psychosis, because carbidopa is a peripheral dopa decarboxylase inhibitor. Dopamine, levodopa will get into the brain, will increase the dopamine in the brain. So that can increase the dopamine. If the dopamine goes beyond the normal limit, it can cause psychosis. So that problem is not resolved even if you give carbidopa. Whereas the T half is increased, half-life is increased, cardiac problem will become less, nausea vomiting will become less, peripheral ADR will become less, response also will be fast. So those are the advantages of carbidopa. So better remember the advantage of levodopa when given along with the carbidopa. Okay, so hope it is clear. Now we'll move to the one more extra point. I told you levodopa can be given in combination with the carbidopa or bensericide. So this combination, the name of this combination you need to remember, co-chiral dopa. Co-chiral dopa is the combination of levodopa plus carbidopa. So remember, co-chiral dopa is a combination of dash and dash. The answer is levodopa and carbidopa. And normally they are given in the as a fixed dose combination. You know, fixed dose combination in one tablet itself, 2 drugs could be there. Okay, so the ratio you can remember either 10:1 or 4:1. Normally levodopa will be in the higher concentration. So 10:1 or 4:1 is the ratio of levodopa and the carbidopa in the fixed dose combination, and the combination name is called as co-chiral dopa. Hope it is clear. All right, so that is the point another point you need to remember. One more point you can remember: when you are giving levodopa for a long term, there will be a fluctuation in the response. When you are giving it for a long term, like 4 years, 3 years, 5 years, there will be a fluctuation in the response. That means the patient will be having different episodes. Sometimes the disease will come down, again it will increase, again it will decrease, again it will increase. So that phenomenon is called as on-off phenomenon. On-off phenomenon. So on-off phenomenon can be seen with the levodopa, because after a particular time, it will fluctuate. There is a fluctuation in the response. So on-off phenomenon is seen with the levodopa. Okay, so that is all about levodopa, carbidopa, benseracide, and all those things. Okay, now we'll move to the drugs which can go and directly bind to the D2 receptors. So already we have told the classification. D2 agonist, they will directly stimulate this D2 receptors. They are called as a dopaminergic agonist. Now, what is the advantage? They are longer acting. When you compare it with levodopa, they are longer acting. And since it is longer acting, they are the more first line drugs or the drug of choice in Parkinsonism. So the most commonly used drug in Parkinsonism is, of course, levodopa carbidopa, the most effective drug. However, the drug of choice will be this D2 agonist, especially the non-ergot D2 agonist. We'll come to that. Okay. So the example I told you, bromocriptine is an ergot alkaloid. It is also called as bromo. You look at the name here. The name, the word ergo is there because bromocriptine is also called as bromo-ergocryptine. It is derived from ergot alkaloid. It is a potent agonist on D2 receptor, whereas it is a partial agonist on the D1 receptor. Okay, so bromocriptine is a potent agonist on D2 receptor as well as a partial, and we of course we need agonist action on D2, right, to increase the dopamine level, because D2 receptors are mostly seen in the substantia nigra in the basal ganglia. So D2 agonist activity is most required, and bromocriptine is a potent agonist on D2 receptors. Okay. However, it is a partial agonist on the other receptor. What is that? D1 receptor. Now, I told you in levodopa, one of the ADR was dyskinesia. Also, this on-off phenomenon. Correct? I told you when you use levodopa for a long term, on-off phenomenon can come. Similarly, in the ADR, I told you dyskinesia. So, when you use a bromocriptine or a D2 agonist, this is less likely. Okay. So, that is the advantage. All right. Now, but however, bromocriptine is not preferred drug because it is an ergot alkaloid. Lot of side effects are there, and one of the ADR you need to remember is fibrosis. Okay, so that is all about bromocriptine. It is also called as bromo-ergocryptine. It is an agonist on D2 receptor, whereas it is a partial agonist on D1 receptor. It can decrease or it can less likely to cause dyskinesia and on-off phenomenon. ADR is fibrosis. Now, moving to the next ergot alkaloid, which is more potent than bromocriptine. The answer is pergolide. Pergolide is more potent than bromocriptine. However, it is withdrawn from the market due to cardiovascular toxicity. Pergolide is not preferred because of cardiovascular toxicity. So these are the two drugs you need to remember from the ergot alkaloid: bromocriptine and pergolide. Okay. Now we'll move to the non-ergot alkaloid, which is used. So in the initial classification, I have given detailed classification and examples of the drug. You better remember that, and in detail, I just remember the drugs what I teach. Okay. So coming to the non-ergot alkaloid, the main example you need to remember is ropinirole and pramipexole. So they are non-ergot, and they are the most preferred compounds compared to ergot compounds. They are most preferred. It is a non-ergot alkaloid. It is a synthetic derivative, and also it is a selective D2 D3 agonist. Okay, and I told you they are the most preferred because the toxicity comparatively it is less. Now it is the drug of choice or the first line drug in the Parkinson's treatment. It is initiation therapy. It can also treat on-off phenomenon. When I told about levodopa, I told you that on-off phenomenon can happen with the levodopa. However, in this case, it can even treat that on-off phenomenon, because when you give levodopa, on-off phenomenon will be there. So you can administer ropinirole or pramipexole to treat that on-off phenomenon. Okay, it is a drug of choice for Parkinsonism, first line drug in the Parkinsonism. Now coming to the ADR, there are a lot of compulsive behavior would be there. For example, gambling. You will be provoked to, or you will be forced to do some practice. Okay. So that is called as compulsive behavior. So increased compulsive behavior can be seen with the D2 agonist. Okay. So hope it is clear. Now, I told you another strategy to treat Parkinsonism is to inhibit the enzyme which metabolizes dopamine. And what was the enzyme which metabolizes dopamine? Yes, MAO-B. So you inhibit this enzyme, dopamine level will be increased, correct? And that example is gilin, seligilin, rasagilin, and safinamide. In safinamide is a newly approved drug for the treatment of Parkinsonism. Also, it can be given for on-off phenomenon treatment also. So that is the MAO-B inhibitor. Just example you need to remember: seligilin, rasagilin, safinamide. Safinamide is a new drug which got approved for the treatment of Parkinsonism. Now, also I told you one more enzyme which metabolizes dopamine is COMT enzyme. So COMT enzyme, if you can inhibit, what can you can increase the dopamine level. Correct? And the example is capone, tolcapone, entacapone, opicapone. One of the toxicity is diarrhea. Yellow-orange color of urine is due to this kind of capone drugs. Okay, COMT inhibitor. When I taught you TB, I told you orange-red color urine. Which was the drug? Rifampicin. When I told about the anti-cancer drug doxorubicin, I told you red color urine, red color urine. Okay, so these are the things you can remember. Now yellow color urine will be the color is due to the COMT inhibitor, hepatitis, rhabdomyolysis. So these are also the adverse effects of COMT inhibitors. Okay, so these are some of the not very important, but you can remember. So now coming to the drugs which can increase the dopamine release. Okay, drugs which increase the dopamine release. The answer is amantadine. As I already told, once upon a time for influenza A, this was one of the preferred drug, amantadine. However, currently we have better drugs like oseltamivir. So amantadine is no longer used for influenza A virus. Now it is can be used for. So sometimes the question will be like, which antiviral drug has effect in Parkinsonism also? So what should be your answer? Amantadine. Or sometimes the question will be like this: an anti-Parkinson drug which is having an effect on influenza A virus. The same answer, amantadine. Okay, the problem with amantadine is that CNS side effect like insomnia, nightmares, etc. Apart from that, ankle edema is also seen. Okay, now one more point. It has, I told you, levodopa, one of the ADR is dyskinesia, right? Now amantadine can improve, or it can be used in the treatment of dyskinesia. The reason is that it has one more additional mechanism. It is an NMDA antagonist. NMDA, you know that N-methyl D-aspartate antagonist. That is a receptor for aspartic acid and glutamic acid. So it is an NMDA antagonist, and that is why it can be used in that improvement of dyskinesia. Okay, so hope it is clear. Now I told you there are certain drugs which can cause Parkinson's, correct? And which are the drugs? The drugs like phenothiazines, the antipsychotic drugs, right? Phenothiazines, haloperidol, butyrofenones. They are called as the typical antipsychotic drugs. Typical antipsychotic drug. Apart from that, metoclopramide. So what these drugs do? These drugs will go and decrease the dopamine level. Okay, these drugs will decrease the dopamine level, and they will block the D2 receptors. They will go and block these D2 receptors. Okay, so when these drugs are blocked by these antipsychotic drugs, can you give levodopa? Can you give D2 agonist? Because the receptor is already blocked. Even if you give levodopa gets converted to dopamine. Dopamine cannot act on the D2 receptor because this antipsychotic drug has already blocked the D2 receptor. You cannot give bromocriptine or pramipexole ropinirole because D2 receptor is already blocked. So what is the next strategy? The strategy is that you need to, rather than stimulating the dopamine system, the one other strategy I told you can bring down the acetylcholine level. So whenever Parkinsonism occurs due to drug, that is called as drug-induced Parkinsonism, the drug of choice should not be any kind of levodopa, carbidopa, or any drug. Rather, it should be the central anticholinergic is the drug of choice. Okay, so central anticholinergic should be the drug of choice in the drug-induced Parkinsonism. And the main example is benzhexol, also called as trihexyphenidyl. Apart from that, benztropine, biperidine, procyclin. So the point you need to remember is that for the drug-induced Parkinsonism, which are the following? So read the question carefully. If the question is, which is the following is the drug of choice for the drug-induced Parkinsonism, don't write levodopa or pramipexole, ropinirole, or any drug in the dopaminergic system. Okay, rather than you write the drug which can decrease acetylcholine, that is central anticholinergic. That is a drug of choice for drug-induced Parkinson's. And the main example is benzhexol. Hope it is clear. Now, since these drugs are very expensive and not available in many places, we have certain antihistamines, H1 antagonist, which is having anticholinergic action. They can also decrease the acetylcholine level. And the main example is promethazine. Okay, promethazine, diphenhydramine, dimenhydramine, because they have what action? Anticholinergic action. Okay, so central anticholinergic are the drug of choice for drug-induced Parkinsonism. If it is not available, you can use promethazine kind of drug. Hope it is clear. Okay, so with that, we have come to the end of the treatment of Parkinsonism. In the medicinal chemistry point, it is not there in the syllabus. Only the point you need to remember is dopamine is a dihydroxyphenylalanine derivative. That is the only point you need to remember. It is a phenylalanine amino acid is present. That's all. Phenylalanine is a essential amino acid. That is the only point you need to remember with respect to the chemistry point of view. Okay, so with that, we have come to the end of the anti-Parkinsonism treatment. Okay.